Hi, this is Dr. ROJoson, Director of the ROJoson PEP TALK. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. I launched this PEP TALK on May 15, 2021 with a module on COVID-19. The second module was entitled Patient Empowerment. I am now on my third module, which is Patient Management Process. What I have in mind in my PEP Talk, which may run for 3 years, is to empower at least 30 persons with my family members and my patients as a priority. This is my key performance indicator. I hope you will be in my group of 30. My PEP Talk today is entitled Patient Management Process, Peculiarities and Limitations of Medical Practice. The empowerment objective is for lay people to have an understanding of the peculiarities and limitations of medical practice that affect patient management process. This is the patient management process framework. There are 6 parts in the module on patient management process: overview, clinical diagnostic process, clinical diagnostic process, selection of treatment process, advice to patient process, and peculiarities and limitations of medical practice, which will be the topic for today. The patient management process is essentially problem solving and decision making of a patient's health concern. It is a complex process in that 1, it involves a lot of steps: diagnosis, treatment, and advice. And in each step, there is a series of actions which are carried out in order to achieve a particular result or goal, the reason for calling the patient management as a process. Second, although there are guidelines in the use of the processes in achieving a particular goal, implementing them do not always ensure attainment of goals. The main reason for this is that there are peculiarities and limitations in the science of medicine and its practice that pose challenges and hindrances in accomplishing the goals 100%. All physicians are fully aware of these peculiarities and limitations and have adjusted to them and have factored them in their management of their patients. All patients or lay people should also be made aware, at least, if not fully understand these peculiarities and limitations, so that they can adjust to them and factor them in their management of their health concerns and issues. This awareness would also facilitate their participation in the problem solving and decision making with their physicians, in the sense that both parties are aligned in understanding of the peculiarities and limitations of the science of medicine and its practice. By the way, I'm using the word peculiarities in the title to mean eccentricity, that is, deviation from the established pattern or norm or from the usual. I may also use it to mean idiosyncrasy, that is, unusual feature or behavior. I'm using the word limitations in the title to mean the greatest amount, extent, or degree of something that is possible or allowed, but not able to achieve the full capability. As we discuss the topic, have in mind the patient management process, and at the same time have in mind the peculiarities and limitations of the science and practice of medicine, and see how the latter affects the former. Here are the maxims, rules, and guides in the management of a patient in consideration of the peculiarities and limitations of medical practice. Basic maxims: medicine is an inexact science. Medicine is an art of probability. Ideal goals or fighting targets in patient management by physicians are the following: resolution of the health problem in such a way that the patient does not end up dead with no complications and no disability as much as possible, and in such a manner that the patient is satisfied. Because of limitations of medicine, the ideal goals for fighting targets in patient management cannot be achieved all the time. What is most important is that the physicians exert their best, rational, honest, and humane or compassionate efforts in managing patients to the satisfaction or delight of the patients, even in the absence of complete resolution of the health problem. Best effort by physicians at all times, cure sometimes, relief often, and comfort always. Nothing is absolute in medicine. There are exceptions to the rules. Anything is possible. There are more than one way of doing things in medicine. There is no such thing as absolutely certain diagnosis, whether it be clinical, paraclinical, histopathologic, or post-mortem diagnosis. The only routine in medicine is a rational decision-making in the management of a patient with a health problem. Rational decision-making weighs the probability of being successful in the achievement of the goals and management of the patient. Rational decision-making relies more on the general rules rather than on exceptions. Rational decision-making banks on the more common rather than on the least common or rare events. Rational decision-making uses the processes rather than gut feel. A rational decision-making may not always be correct. As long as the decision is rational, it is acceptable. A rational decision-making is more often correct than wrong compared to an irrational decision-making. Diagnostic process and the diagnosis. The diagnostic process must be rational for it to be acceptable. A diagnosis that is based on the rational process is not always correct. However, a diagnosis is more often correct than wrong if it is rationally arrived at. And a diagnosis is almost always an educated guess. Interview as a diagnostic tool. Identify the chief concern or main problem of the patient. Once identified, use it as a steering wheel in the diagnostic investigation of the patient. Inquire on the circumstances associated with the chief concern. Inquire on symptoms. Symptoms are those manifestations perceived by the patient. Get clues from the circumstances and symptoms to be used in the diagnosis of the patient. Be effective, be complete, be efficient, be relevant. Know how to get cues from the data and how to interpret data. Know which data to pursue, to put in the background, to use in the diagnosis, not to use in the diagnosis. Fiscal examination as a diagnostic tool. Use the identified chief concern or main problem of the patient as a guide in what to examine. Look for signs. Signs are those manifestations perceived by the physicians. Get cues or clues from the signs to be used in the diagnosis of the patient. Be effective, be complete, be efficient, be relevant. Know how to get cues for the data, how to interpret data. Know which data to pursue, to put in the background, to use in the diagnosis, not to use in the diagnosis. Interview and fiscal examination can be done in any order as dictated by the circumstances. and they can be done simultaneously. The goal of interview and physical examination is diagnosis. Correlate data from interview and physical examination to come out with a rational clinical diagnosis. If there is a question on which data to put reliance on, choose the sign data over symptom data. Remember, however, that for the sign data to be reliable, they must be accurate. Clinical diagnostic process. A clinical diagnosis is one that is derived from the interview and physical examination, or put it in another way, it is one that is derived from the symptoms and signs. Essentially, two processes are used in coming out with a clinical diagnosis. These two processes are pattern recognition and prevalence. Pattern recognition means the realization that the patient's presentation conforms to a previously learned picture or pattern of disease. Prevalence means the choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age group or sex group, and in the affected organ and system. Elemental steps in making a diagnosis: identify which organ, tissue, or system is involved, then identify the disease in general terms such as inflammation, infection, tumor, trauma, endocrine, etc. Then try to be more specific in identifying the disease, if possible, such as malignancy or malignant neoplasm, abscess, etc. Knowing the nomenclature of diseases facilitates diagnostic labeling. Paraclinical diagnostic process. After the clinical diagnosis, the next step is to determine whether a paraclinical diagnostic procedure is needed or not. A paraclinical diagnostic procedure is a diagnostic procedure that is done after the clinical diagnosis is arrived at, and its objective is to make the diagnosis more definite. To decide whether a paraclinical diagnostic procedure is needed or not, a physician should consider the following factors: how certain he is with the clinical diagnosis, and whether a more definite diagnosis is needed or not for some reasons or another. Once a decision is made that a paraclinical diagnostic procedure is needed, the next step is to choose the most cost-effective procedure for the patient by doing the following: tabulate, compare, and analyze the options, and give the BRCA data like this. B stands for benefit, R risk, C cost, A availability. After the paraclinical diagnostic procedure has been done, the next step is to interpret the result. The result of the paraclinical diagnostic procedure must be correlated with the signs and symptoms of the patient to come out with a pre-treatment diagnosis. Selection of treatment process. Selection of the treatment procedure is based primarily on the pre-treatment diagnosis. Select the most cost-effective treatment for the patient by doing the following: tabulating, comparing, and analyzing the options and their BRCA data like this. The final decision on the type of treatment to institute will rest on the patient. There are two special issues related to limitations of physicians that I'd like to discuss today: knowing when and to whom to refer, and second opinion. Knowing when and to whom to refer. There will always be patients whose health problems will be beyond a physician's existing competencies. Such patients may have a very unusual health problem whose diagnosis is extremely difficult. Such patients may have usual health problems, but whose treatment is beyond a patient's or a physician's existing competencies. Example, a primary care physician who have not been trained to do a surgical operations. True to all physicians, regardless of the amount of training and experience, there will always be patients whose health problems are beyond their present existing competencies. When to refer, all physicians must know their limitations. Only they themselves can determine their own limitations. They must realize their limitations so that they do not cause undue harm to their patients and so that they know when to refer to colleagues. Refer means asking for help from and conferring with colleagues. Referring a patient to a colleague may mean totally transferring the care of a patient to him or continuing to manage the patient with his help. A proper communication, either oral or written, is in order. Referral must be made to somebody who may or can solve the patient's health problem rationally, effectively, efficiently, and humanely, and who has a good track record of handling the kind of problem on hand. Second opinion. This means seeking another opinion on patient management from another physician or healthcare professional. Second opinion can be sought by both physicians and patients. Physicians seek second opinion from medical colleagues when they realize their limitations, when they are beating their heads against the wall in trying to know the true diagnosis and how best to treat the patient. Physicians can informally communicate with their medical colleagues from whom they want to seek an opinion, or they can formally advise the patients, such as give a referral letter to seek a second opinion from another physician. Patients, on their own free will, seek second opinion from another or other physicians for at least two valid reasons. One, patients are not fully satisfied with the explanation of the first physician, either no or incomplete or unclear explanations. Patients want to validate the explanations and recommendations of the first physician because they're hesitant to accept the recommendations, and they hope there will be different recommendations from the next physician congruent to their personal desire. Note, seeking another physician is not always equivalent to seeking second opinion. Seeking another physician may have other reasons aside from second opinion. Patients may be primarily shopping for physicians who can offer the best or affordable medical expenses. They may be looking for other physicians whom they can communicate better and with whom they can have better rapport, trust, and confidence compared to the first physician. They may be looking for other physicians because of the convenience of continued medical care, such as physical proximity of the clinics, of the physicians, and their affiliated hospitals. All patients have the right to seek second opinion for whatever reasons they may have. Nobody will, can, and should question the reasons. The basis for this, all patients have the right to make their own choices and be the primary decision maker with regards to their health concerns and issues. Also, they have the right to seek medical opinions from another physician after the first and to as many physicians as they want. The formal subjective indication for a second opinion should be if the first physician is not explaining or not advising well using rational patient management processes in diagnosis and treatment. If he does, there may be no need for a second opinion. If he does not, there is a need for a second opinion. It is not wise for patients to seek second opinion all the time, only as needed or as indicated. There are benefits as well as potential harms in second opinions. A benefit is facilitation of proper problem solving and decision making. Potential harms could be confusion because of so many differing opinions, getting wrong advice, and doing wrong problem solving and decision making. Simply going by plurality of opinions is not as strong, not to say valid, a reason in seeking a second opinion compared to the foremost indication as mentioned above. Going by plurality of opinions is no assurance that the recommendation is correct and should be adopted. One may end up choosing the most popular medical opinion rather than the most rational one, backed up by good processes. So if one seeks second opinion, beware of the danger of seeking from physicians who do not use the patient management process to explain or advise. The advice given may just be based on current trend and fad and not based on in-depth analysis of the patient's actual medical conditions, inherent psychological makeup of the patient, and not based also on concrete medical data, information, and evidences. I will end my pep talk for this topic at this point. Takeaway in this pep talk that are related to patient empowerment. Understand the peculiarities and limitations of medical practice as they affect patient management process so that you will not be frustrated with the outcomes. Be ready to ask questions if the physician is not advising you properly and adequately on the peculiarities and limitations. Participate actively and fully in the problem solving and decision making of your health concerns with your physicians, factoring in the peculiarities and limitations of medical science and practice. Master the peculiarities and limitations of medical science and practice as they may help you in some way in deciding for your own health concern in consideration of the oddities or complexities. This is one other way of gaining greater control in your health concerns and issues. So with that, I end my pep talk today, patient management process, peculiarities, and limitations of medical practice. I hope I have empowered you to have a better understanding of the peculiarities and limitations of medical practice as they affect patient management process. With that, I say thank you for your kind attention and mabuhay kayong lahat.